Death in the community has become a very lonely time during the pandemic. This is just one of the responses from our recent survey to try to understand the role and response of primary healthcare services, so GPs and district nurses, who have delivered the majority of end-of-life care in the community during COVID-19. This is important research. COVID-19 has seen a sustained increased need for end-of-life care in the community, with more and more people choosing to die at home. Primary care have a really critical role in the delivery of that care, but receive a surprising lack of attention in policy reports and through research funding. So it is fantastic that the Royal College of General Practitioners Scientific Foundation Board have seen that this is an important area for research, and this short presentation will explain why I feel the research is so important and the opportunity that that grant has provided. End-of-life care in the community was by no means sorted prior to COVID-19, and in 2016, a survey we carried out with the Royal College of GPs outlined quite a number of barriers to improved end-of-life care in the community, despite lots and lots of national policy advocating and calling for better end-of-life care. Factors were related to difficulties in providing continuity of care, particularly with out-of-hours services, a feeling that it was difficult to provide enough support for families and carers in the community, that symptom control and access to palliative care, support and hospice beds was inconsistent, and that there was quite a diverse range of formal training, knowledge, skills, attitudes, confidence and experience amongst GPs. When the pandemic hit, it became very clear that primary care was going to have to play a very key role in the delivery of end-of-life care in the community, but there was almost no research from previous pandemics to inform us about how to make those changes in practice and service delivery during the COVID-19 pandemic. So we got to it as quickly as possible, and we quickly devised an online survey to gather the views and experiences of primary healthcare professionals across the UK. We had ethics approval from the University of Sheffield and sent the survey out between September and October 2020. We've had 387 community nurses and 156 GPs respond to that survey from all areas of the UK and mixed geographical areas. All had delivered increased end-of-life care in the community throughout that first phase of COVID-19. What the survey told us was that in keeping with the data, more end-of-life care in the community was needed. And it was not just volume of patients, but it was also the complexity with which patients were living that provided challenge. There were contrasting roles for GPs and community nurses. GPs followed guidance to increase their remote consultation, so district nurses did the majority of face-to-face end-of-life care. Their experiences of support from general practice and from specialist palliative care services was variable, and some reported really significant feelings of isolation and vulnerability in delivering that end-of-life care face-to-face. Meanwhile, GPs experienced considerable moral distress, feeling that they couldn't deliver face-to-face care in the way that they would like to for patients who were dying in the community. This has led to a significant emotional impact for some, both general practitioners and district nurses, and we identified a real need to rebuild those community multidisciplinary teams in order to deliver that sustained increased need for end-of-life care in the future, and really feel that more research is needed. This is an important area, and if we don't do the research, this narrative won't be heard going forward and in future pandemics. So the recommendations from that first survey were that we need to recognise the sustained increased need for end-of-life care in the community and the critical central role of primary healthcare services. That we must prioritise trusted relationships and integrated approaches to delivering end-of-life care in the community. That policy guidance should support the multidisciplinary team relationships, not just the roles of specific services, because that's how it can become fragmented. And that we must support individuals through team relationships, increased training opportunities, and that debrief that can occur within teams. And more research is required. And this is where this grant from the Royal College of GPs has come in, because it has allowed us to take research forward. So thank you, Royal College of GPs, for making it possible. We've been able to appoint a research associate, and we have worked on a further analysis of the survey data, focusing on what primary healthcare professionals reported did work. So how they use new opportunities like virtual online team meetings to improve the end-of-life care that they delivered, what they found helped in terms of responsive services, and tried to focus on some of the positive learning, and that paper has just been submitted. We're now sharing the findings as much as possible of that first survey, and the paper has been accepted in the BJGP Open, and also the findings are presented in the conference poster here, poster 18.3. We're able to further progress the research through the conduct of a qualitative investigation now, interviewing community nurses and GPs about their ongoing commitment and role in primary palliative care as the pandemic progresses. And our aim is that we come up with a model for pandemic primary palliative care, recognising this essential part of the jigsaw as the pandemic progresses, and at any time actually when there is an increased need for end-of-life care in the community, which is most winters in the NHS. Commissioners and those in command and control structures should have a model they can pull on to understand what needs to be mobilised into the community to meet patient need. And that's the aim of our research funded by the Royal College GPs. So thank you. I've been privileged enough to work with a fantastic study team from across the University of Sheffield, Edinburgh, Warwick and the University of Cambridge, and I need to say thank you to the University of Sheffield Palliative Care Studies Advisory Group for the patient and public involvement that keeps us going through the research. Thank you very much.